very good morning to Dr. Rao, Miss, veteran sisters, my fellow colleagues. So my today's presentation will be divided into two basically. First, case presentation, and then proceed with our discussion on the case. So basically, history. 6 years old girl with no previous medical problem or hospitalization was alerted earlier on, alert submersion into Ulu Crown River and brought by Hospital Damai with father to EDHKL. So we follow the TKM method. So on arrival, how do we assess this patient?
The patient actually not from Hospital Damai. The father brought him all the way from Ulu River to our hospital. Okay, what should we do at the triage?
Any triage officer like me?
Okay, Max, you kena ambil sebelah ni.
So upon arrival, patient arrived around 2:30 PM. Is it during busy ED shift as usual at peak hours? So how do we assess this patient? What do you look for assessment? Currently the person is 1 to report. Any further assessment you want to assess the patient? So airway wise, we got some secretions because brought by parents, and then breathing, still spontaneous breathing. What further assessment you want to look for? So, any other differential diagnosis that we can think of with this kind of presentation?
Question being asked by Dr. Rao. As the person who sees the patient in front, what goes into their mind? You are correct as far as syndromic interpretation. But other than that, we must actually try and analyze furthermore. Some people see submersion as simple, mere drowning. Some will have something more in their mind. So different people will have different things in their mind. So what I would say, just try and go a bit deeper. Ask them whether they understand the concept of why do they want to send to research. What is the big issue?
What do you think of when patient is actually brought to the hospital under submersion? So what further history or further data that we need to support or to in this case to ensure whether it is actually really submersion injury or submersion or other different diagnosis is still possible?
To re-emphasize the point that third time, found unconscious in the water, yes, pulled out, CPR commence. Because if the girl fall, there's another element to it, you know what I mean? Because if you talk about the car park is so close to the river, you can jump into the river. I'm going to look for where this will be. Otherwise, if the girl fell into the river, there may be something more than this, you know. That there may be some trauma, fell into something, you know what I mean? Next time when there is this concept near drowning, duration is very, very important. Number two, when you say you pull up the girl from the water, found unconscious in the water, actually, you must really know how was the baby or the girl when the girl was drowned. That's extremely crucial. Because the status at that time will determine the prognosis. When you talk about near drowning, now then you must mention another one. Fresh, non-polluted. Now after the water you must say whether it is, what is the type of water you have? Oh. Fresh water or salt water? It's two different effects. And then the other one, of course, polluted water. Polluted water is now. Anyway, so when you talk about, if you say swimming pool, the impact is different. If you talk about sea, it's different. If you talk about longkang, it's completely different.
So subsequently, the patient actually was sent to hospital to Ramai by the bystander, also by the father. Further assessment in this case. So alert submersion injury, I would like to assess in this case. We have to bear in mind, from this history, we don't know how the patient fell into the reverse and whether there is prior to fall, whether the patient is unconscious, whether there is some elements of trauma in this case. So what do you assess? What do you assess in this case? Usually, if you say if you are working in resuscitation, actually every is got some situation there, but patient still breathing, but tachypneic, semi-conscious with DCS of 7 and faint and foolish on touch with temperature of 36. So what are the assessment you are to specifically look for?
This examination will be done to try and look for what is in your mind. Now, whatever we do from now on is really depend on what is the real situation and also in our mind. All this is just a simple examination. But if you were to see the patient, how would you like to examine the patient? What would you like to do first? Thinking that this baby now is semi-conscious, 7 GCF, pale, and cyanotic. Good. Okay. First concern, airway. What is airway like? So you want to know what's the airway like?
Yes, airway actually is still better, but very minimal secretion with.
Okay. What do you think? Minimal secretion. Now, just also we are not going to think. If you are there and you pick up, you are together at that point. And anyway, this one is after the patient has been managed in Dharma. Okay, so you can discuss which one. It doesn't matter. Spontaneous breathing, tachypneic, semi-conscious. What do you think? What is it of physiology? Do you know? In the day around. Because whatever you do next, depending on what you have in your mind. You say something about aspiration, you say something that water in the lungs. That's fine. What would you like to do with that? Hypothermia in this country is to tell you those are what you read in the textbook. Actually very nice there. From a very warm weather you dive into the water, actually it's very cooling. In fact it's much better. Not worry about hypothermia per se, because yeah, if you are soaked for a long time, maybe. But even then, water temperature is never really can cause hypothermia. These are all the things that you read from the book. Hypothermia is not a big issue in this country. But now the core body temperature can give some metabolism, but truth is, the paradox is actually it's not the issue of temperature. Okay, don't worry about the temperature. The temperature issue in this country is not big. For your information, even if the body is cool for a while, it's quite true. But then, okay, don't worry about the hypothermia. What else is important? What is the most important thing in this chapter? Okay, what is the biggest issue in your drowning? That's what I want to ask. Because you all are emergency doctor. Because you may be at the side, or now you are in the department. So you have to have knowledge to be able to manage it. So what will be your concern? That's all I want. This will only happen, the longest is about 30 seconds to 1 minute. Is how long you can withhold your, how long can you withhold your breath without oxygen? Most of you for 1 minute. Yeah? Maximum. After 1 minute, you cannot put anymore, and you will swallow all the water. After 1 minute, so the water will go into your system, and you will flood your lung. Okay, that's near running a lot. So that's why when you fish out anybody from the water body, the first concern is to remove as much water as possible. You cannot do CPR. If you do CPR, there will be water coming out and it will go in again. The first step is to actually remove as much water as possible. And then of course you conduct CPR. Everybody must do this because the first concern is about water occupying the respiratory. Is that clear? Now the second, of course, we talk about the pathophysiology, the hemolysis and all that, that will be later. Now actually hypothermia is not such a big issue in this part of the world. That is the instinct you must know, and I think that's why we need to know the duration. If the patient has been in the water for a while, about 5 minutes, by that time the lung is completely flooded. And when we talk about submersion, we talk about whether the body is actually found in the water body or otherwise already floating. You know what I mean? So that's another situation. Later on, resuscitation include removal of the fluid, and then of course you may want to protect the lung or whatever else. Okay, SpO2 and AD, for all this actually is the second already after the initial phase. And that's what we are trying to discuss is that ask everyone and say, you next time see a case near drowning, don't muck around, don't bother about all these things. Just take patient to the resusc, bang the patient's chest and remove as much water as possible, and then either you want to see whether the ventilation is adequate or not. Because you cannot, there are still water in the lung which you cannot remove because it will be right at the basal and so on. So if you ask the patient to continue breathing on their own, it may not be adequate. Here now, there may be some atelectasis. Later on you must tell us that. The physiology of near drowning so that they know why you want to act like. Okay? Yeah.
So I think the duration of then once the patient was intubated straight away, went right to ED. Actually, so basically I discussed on drowning. Basically,
you said patient is intubated by the way.
Yeah.
Now that is important. Why do you do that? Then you tell us why. Because okay, right now I said you bring the patient to the resusc, yes? And then you do a bit of physio, you remove as much of water as possible, and you look at the patient, with the patient conscious, or he acting to you, whether there's, you look at the cry, movement, you see, look at the movement, look at the cry, whether the patient is struggling actively or patient is really weak. Okay, how's the condition of the patient now? Is the patient weak or movement or active or what? Bearing in mind CPR has been done for 10 minutes.
CS actually stable, moving all limbs, but still
active or like many of them here?
On documentation they said still.
You say you intubate. Is intubation important or not, and what? Let's discuss that. Okay, intubation. What about intubation? Are all patients near drowning we must intubate? Yes or no?
Not enough ventilation and also.
So you think the ventilation is inadequate? Yeah. You think there's a lot of fluid in the lung, so you intubate. Fair enough. That's not wrong. In another situation, you think the patient is active enough, breathing a bit, and I don't think patient is active. That's also okay. I mean, but please, when you present to us, you must know why. Every step is important. Okay, so
post-intubation, of course, package of management include airway and then post-intubation care.
Okay, one slowly. Okay, airway intubated, tackle. Okay. So you use fentanyl, midazolam, and succinylcholine.
We rarely use fentanyl and Masterclass. To begin with, the PCS is not yet because of us.
Yeah. Okay. Just mida. Somebody just said mida. Anyway, mida. What mode you give on ventilation anyway after this? What is the mode of ventilation you give? That's the problem. Okay, that's the reason why I asked. What's the problem when you want to put on SIMB mode and you give all these things? Saksa will be about what, 5 minutes, 10 minutes, the patient will be okay immediately if the Saksa is gone. Can somebody tell me when you give Saksa-metonium, what can happen? What will happen when you give Saksa-metonium?
Any important side effects?
In this case, we have the possibility hyperkine. Hyperkine is there is not imbalance as well.
Full marks in your OSCE. Alright. Malignant hypothermia, very rare. Only have one case in Malaysia, very rare. Transient hypokalemia, yes. What else we have to do with aging? Anything you can help if these patients are very sensitive and they have higher vagal tone, when you give subsolutorium, it's a depolarizing agent. That's why you get reticulation. Why you get reticulation? All the ACH acetylcholine can reticulate. But this is nicotinic receptors. The acetylcholine is also a transmitter for your vagal parasympathetic. Vagal parasympathetic. You get bradycardia. Be careful with the child. So that's why our pediatric colleagues, they're very particular. First rule in any kind of pharmaceutical intervention in a patient, try to minimize. You really need 3 and opiate can. An opiate, a very potent opiate, or already a benzodiazepine, and then the powerful depolarizer. That's why our kids use minimum amount of benzodiazepine. Like adult.
Physically, or when you are intubating with full stomach, this one have a lot of fluid in the body. Yes. When you use subsubitonia, you really have to protect. Because our worry now, if the patient got into her lung water only, okay, that's bad, but not too bad. But if you give subsubitonia, the patient will into circulation, and you want to press on the thyroid and you want to prevent from aspiration, it's very difficult in child, very difficult. And then if the abdominal and the stomach content goes into the especially with this is really like a pregnant lady situation where you imagine that probably the stomach is full of water and it will combine with the stomach content. And it's not easy. So this is why I keep asking what Faisal said, yes, and plus 1 more. Now this is the issue. Well, you can give anything you want, and patient can survive, and you say okay. But my worry is you do it many more times without realizing the implication. We are here to remind you that in fact go a little bit less aggressive. Like what Rao is telling you and what Faisal is telling you. You cannot. It's not aggressive in a way. It's about to take caution of all these things that you use. Now some of your partners also use. But I say, oh no, I can maintain. In fact, when I was trained in anesthesia, there are theories. But there's some of these anesthetists, senior anesthetists, they do it anyway. And then we say, why you do this? I was okay, I'm confident. This is what I see. But whatever you do, if you are confident, but still there is a reason for it. So you give all these 3. Now if you later on want to put patient on SIMV, with all these things on board, you think patient can breathe. Patient will be zonked, And this circulation actually makes patient very exhausted because this circulation is running at the same time. And then you immediately put them on SIMV. You don't put it. So this is why you might want to ventilate the patient for a while. In fact, we'll discuss about what mode you want to give. Now, for this situation, you may not want to think by SIMV immediately because you are not going to be able to get put into this. Okay, fine. Any comment, anyone else?
The main concern when you give saxamethonium is it will cause bradycardia. That's the main concern in pediatrics. That's why instead of giving fentanyl in pediatrics, we give atropine as the free medication. Pre-med we give atropine, not fentanyl. And sometimes it can go into resistol as well, when once you give the scoline. So that's why we try to avoid but there's no threshold that you can't use it at all. So you use it with the proper dose, which is 1 to 1.5 milligram per kilo. And usually in pediatric, we will try to incubate with the benzodiazepine alone. So if you can't, then you can always give scoline, but the proper dose should be given, and before you give scoline, you must prepare for this.
Another one is this, okay, you just put that ETT size 5 cup. Put the word cup there, first. Why I ask about cup? What cup? Why? Why I brought this issue up? Why about cup? What about cup? Now this 6-year-old, you choose to give ETT size and then you put cup, is there an issue?
Issue is actually the complication from the cup can cause the stenosis later on, and edematous will cause the edema to the trachea.
Edema, ischemia, and so on. Just to mention to you, yes, you have to put cup. You must tell me, yes, I want to put cup because I want to protect the airway from the abdominal content. But we must remember that cup also cause problem, especially in a very young, delicate trachea. Because in fact, in young, delicate trachea, we rather not use cup. However, in this situation, you say, I want to use cup because I want to protect from the abdominal content. So there is a discussion there. One, we in fact, in a normal situation, elective surgery fasted, fasted, and then no, we don't think there's abdominal content in big way, we can put non-cup. Is that clear? But in certain situations like this, you don't have a choice. Despite worrying about the complication, you put cup because you want to protect the lung. That's why. Okay. I know.
Other package of management include intubation cares, which is sedation, and also we insert the rice tube to decompress the stomach as well, because the stomach a little bit standard in examination as well. So ventilation with the SIMAV mode for this patient with output of 1, low peak, so with the volume of 120, and IE ratio was 1 to 2, and pressure support was 12. So also we proceed with hypothermic management in this case, in view of we afraid of hypothermia in this case. So started on warm saline and given warm blanket, and further on we refer to the respective MPOs, to PITS medical and also PITS ICU MPO.
This time, what if they SO2 or BO2 after that?
After that, this is actually post-intubation, got severe metabolic
After how long? After how long?
This one, they documented how long after.
Immediately or immediately after? Immediately after the intubation.
But immediately after intubation.
Now post-intubation, let's have a look at that. PO2 still 8.85% still. pH 6.
It's not PaO2. SpO2 is actually post-intubation is 100 lah. By cup was 12 with PCO2 of 107. So got severe acidosis, which is actually mixed respiratory and as well metabolic as well.
What would you do on this? When you see this, what do you think is happening?
It's actually mixed because of the hypercapnia in this case, because of the inadequate ventilation. On top of that, because of the hypoxia and also because of the some hypothermia cause poor perfusion, and also high lactate later on cause acidosis as well. In terms of the CO2, actually we can adjust the setting of the ventilation. Either we increase the rate or the IE ratio.
Okay, let's see. Let's just discuss. Let's try next time around when you find this situation. Please give your interpretation first. What do you think? Give us an interpretation and what should be done. 1, 2, 3, 4. Next time when you see this, talk to investigate. You can get up as well. Because you have to answer. All the ones who get up and give us your opinion. Okay? Now this has been found. This case is near drowning. Intubated on SRB mode. And then now this is after post-intubation, after you post ventilation, and whenever you are done, so then now tell me what do you want to do? What is happening with you? Okay, just simply, okay, what can cause this? That's all. This, we all know already the history. This is near drowning. What can cause this? And what would you like to do? So you think that this is inadequate ventilation. Okay, is this a severe, what is the rate, what is the degree? Moderate, severe, severe. Okay. Now if this is severe, what would you be aggressive, or would you like to do what you are trying to do? You want to increase the rate to 1, 2, 3, 1 to 4?
Basically, the fix adjusted the rate and also
What did they adjust it to?
they increased to 15 the rate from what it was admitted, but subsequently within a day, patient the ventilator rate able
No,
to
we cannot talk about within the day. I'm talking about when you see this result at that point in time, what you want to do. Please understand, you know what I mean? Because see, you can continue what you have done. But we are not, it is not right or wrong, you know, because at the end of the day, there must be a justification. So, we may not agree to this. Look at the chest x-ray. This is the chest x-ray here.
post-intubation.
Yeah?
Post-intubation.
Post-intubation. Well, now what do you think of that? Intubation. Where is the opacity located? More of perihyla, and it is fanning upwards. Right? So what is that? Most likely. Actually, it's a combination of everything. Okay? You can have everything in this situation. Most likely, what do you say? I can hear some sound. Hyperemic lung and a reaction, some form of inflammation, and it's from perihyla upward, fanning. That's called classic fanning. Okay, on this side especially. On the right side, yes, that's a classic way of aspiration. The picture on the left and right is different, right? On the right is very soft, snowy-like, and more so very perihyla, and actually the classic of an aspiration. On the right. Did I say that? Yes, on the right. On the left, what is that? It's more at the parenchyma itself, not much at the perihyla. Actually, it's a massive lung. Okay, affecting the lung, in fact, the whole both parenchyma. More so, if you look on the right side, it's very, very severe aspiration. That in itself gives you the reason. But more so, there is fluid in the lung. Now, the difference between that is actually fluid in the lung parenchyma, not fluid in the pleural cavity. Because the fluid is all in the lung. That's why you don't see the obliteration of postoperative angle, because the fluid is in the lung and the patient is on supine, so you can see the fluid in the lung. Is that clear? So that's why it looks like that. Whereas if you look at on the left, on the right side is aspiration, the reaction of the lung to the fluid that went in due to the acute angle of the bronchus. Is that clear? So that's what it is. So now when I ask you what is on the right side, on the left side is fluid in the lung. Fluid is not in the pleural cavity, because that's why you don't see postoperative angle obliteration. Is that clear now? Right. So whatever the case may be, it is very severe. So this, what is the implication? What is the implication? And now if this, and you see the ABG finding, does it correlate?
Yes.
Yes. So it correlates with the finding of the ABG. What is the pathophysiology? What's happening now? How do we treat this patient? Already there is aspiration on board.
Because when aspirated, the fluids went into the alveoli, and
Okay.
then
So the alveoli is?
wash out the spectrum and causing the atelectasis.
So alveoli will be collapsing. Actually, I said there is not enough oxygen exchange between the lung and the. So what do we need to do?
You give high peak. In this patient, you have to give high peak due to the atelectasis. Then FiO2 high, FiO2, and also you
Let's go to
must
the
increase
ventilation
rate.
mode. Let's go to the ventilation mode. Okay, now this one. So yes, Ibrahim.
increase the feed is too low. So now there's atelectasis, we want to expand the alveoli, keep it expanded, so give high feed. And then IE can be prolonged, and also the rate is not there. So the rate, we can put it as high, put high rate as well. Increase the rate, increase the feed, and also prolong the IE.
Okay, so the main thing right now we are talking about post and expiratory pressure. We want to open up the alveolar. Agree? So we want to do that. So increase speed. Actually, we don't worry too much because now by increasing speed, we not only open the alveolar, we actually push out the fluid. Is that clear? So we want to push out the fluid as well. And we want to maintain a longer exchange time. Okay, in fact, some more aggressive, you don't even put the SRMB mode. You actually completely take over the ventilation. Can we do that? Why don't we do that? Rather than SRMB, why do we ventilate the patient completely for a while? What do you think? Zachary?
Because I think the medical officer or the attending team, they are not familiarized with other mode of conditions.
Right?
So that's why I assume that the SME mode is choose in this case.
Good. So what would you propose?
So if you want to take over the ventilation, then you need to go on the full mode of ventilation, assist, control, VAC. Then you can, because our patient presented with severe metabolic acidosis, then you need to keep the minute ventilation at the high. So minute ventilation should be more than 10 to 12. In my view, if you keep the minute ventilation is high, patient may have developed barotrauma. Because in order to give high minute ventilation, you need to give high rate. So high rate with high tidal volume.
Okay, let me. So far, what you say makes sense. The only thing that not so correct is for now you don't have to worry about butterfly. Why you don't have to worry about butterfly? Because you actually, when you take over the ventilation fully, you push in the fluid. We are more concerned about a collapse alveolar rather than worried about rupture alveolar. Is that clear? In this situation now, if you ventilate the patient, worry about barotrauma, there is a probability. But the death due to atelectasis is real. Is that clear now? So why you worry about that? Don't even think about that for now. Yes, you will. But that's why I say if you take over the ventilation fully, for a while, ventilate aggressively for some 6 hours or so. That will do the job, I think. Rather than hoping the patient can breathe by SIMP, where the lung is so terrible. That is terrible lung actually. A lot of fluid everywhere, and only there is aspiration. What do you think? Anybody agree? What is agree with me? No, you already you agree with me? You definitely agree. Somebody, what do you think?
When patient is not SIMP, actually patient will be the breathing will be provided. Patient is breathing. When patient starts breathing, we will support. And if I look at the trend of the intervention of the team, that it works by increasing pressure, it works by increasing the heart rate, the CO2 goes down, the oxygen goes up. In the end, it was power. So they actually increase the peak to push the fluid back out of the alveolar. The tidal volume has been somewhat maintained, about the same, but they play around with increasing heart rate to increase the volume.
What time the patient around here?
Year 230.
You look at that. At 5:35, the acidosis improved. Okay? My problem with that, Azaman, is this. That's why I'm very aggressive. Actually, my worry is the impact of this, all this metabolism in this manner may cause further damage. My idea is actually when we be more aggressive, we want to reduce the damage of the Now, of course, when you see the trend, it is okay. But me, I have this comment to make that we are losing so much time. Because actually look at 4 hours or so we take to improve the situation. That's the mode that we're using. But probably we can get better off if we would be more aggressive. That's what I'm saying. But it still can be correct, and I still can be wrong. But I'm just saying that if it was me, I would do that. That's all. Because I would be more aggressive. I want to take over for 3 hours or so, or maybe then I will just repeat the X-ray again and again. Because now if you look at it now I tell you what happened. From the 2 o'clock, 1 o'clock to 5 o'clock, there's some 3 or 4 hours we are actually using. But the impact to the patient is real about the brain oxygenation. In fact, we can get increased ICP and many more things happening there, you know. And then the renal, the worry about the kidney. And these are the things that is all that is that we may get into problem of metabolic multi-organ failure if we're not careful. That's why I'm being more aggressive. I suppose it's okay too, but then I don't know. What do you think? Okay. Well, what do you think?
What was the potassium?
Potassium actually normal. Usually 3.7, but subsequently 4.4 the subsequent day. On the method is
sometimes along the way you do not know the potassium level in these patients, but patient from the first instance was given calcium in hospital Dama. It has to be for some reason because the only reason I thought that maybe they take it as well. From here with the severe metabolic mixed metabolic acidosis, patient was given the sodium backup along the way as well. So the only thing insulin was not given or not a cocktail given. But sometimes in drowning patient we do get the struggling, the muscle, in fact.
No, if you look at what's creatinine,
The rhabdomyolysis may which is the fact that sometimes they do come with high level which kill them. So these are some things that may be considered, especially if it's somebody who's struggling, being carried away along the way, you know, in the liver, and sometimes we may need to think even before the result comes back, especially if there's a arrhythmia, and especially patient resistant, especially during resuscitation. There's nothing to lose to give that away because that is a possibility that
CPR itself will cause that also. CPR itself will cause. Anyway, yeah, so we are also worried about the muscular, what we call damage and everything else. Yeah, okay. Now let's move on. So, okay, we'll take it whatever has been done. Let's move on. We're running short of time. So patient was sent to PICU. Support. Okay. Anything else you want to tell it?
So,
okay, continue your presentation. Give you time.
so something about the availability of an application called EM PGY3. You can download your smartphone. It costs about $2. All you need to add in is the weight of the baby and the length in centimeters, and you will get everything: the drug procedures, for intubation, the size, the ventilation, the setting, and everything. So it makes your life easier.
So what I want to highlight here is actually subsequently patient was admitted in PICU within overnight. Subsequently patient was able to be extubated the subsequent day. This is actually the same day as X-ray. Actually they adjusted the ET tube because of too deep. As you can see, still got haziness there. So progress actually, if you look at patient just the short duration in the ICU was ventilated only less than 24 hours and subsequently was
Don't use the word good neurological outcome. I tell you, this is very important for the child. Wherever there is a hypoxia, there will be some form of neurological damage. So you will not know now because the impact will be later. From a smart child can become like some of you. So no, I mean, we won't jump to the conclusion for now. Okay, we will jump to the conclusion for now. I think I suppose you want to say that the neurological, motor, and sensitive power, but brain-wise, we don't know.
IQ. So patient was surprised. Surprisingly was discharged a day after. The admission actually about 3 days only. So in terms of the drowning, actually there are some update on the drowning. This update is actually on 2015. They revised the definition of the drowning. Previously, they used the terminology. The near drowning is essentially the survival of the within 24 hours. Past 24 hours post drowning, and if drowning, essentially death within 24 hours. And but recently they proposed a new recommendation, which is can proceed. Okay.
Then look at that first. This one, the last one, immersion syndrome. Please look at that. Yeah, that is now the later terminology, what we call immersion syndrome. That's what we are trying to ask a triager and so on to understand. Sudden death probably mediated through vagus nerve due to cardiac arrest after contact with cold water. Now this is actually more so if you have in a situation where it's not so much cold water, it's just water, because there are a lot more other things that can happen. Now, I said to you all just now, the nomenclature have changed. Before we talk about near drowning only, drown means dead. But then now they say drowning means die within 24 hours. Okay? Now near drowning is past 24 hours. So when you put patient in ICU and then die after that, then it's near drowning. Now secondary drowning, death from complication after 24 hours. Then cut the long story short, actually now we rather than we just put submersion or otherwise near drowning. Okay? Next.
So they divided into fatal or non-fatal. If non-fatal, whether got morbidity or not. And then
this is retrospective.
Yeah.
So you only can tell whether fatal or not is after the end of it. So you cannot use this terminology because during time when you are examining the patient, you just have to define whether it's near drowning or whatever.
So this is the
okay. Now the other one is the respiratory impairment during drowning must occur, but then the dry and wet drowning. And please explain that.
Okay, the dry and the drowning, we got two pathophysiology, dry and wet lah. Dry is when the fluids irritate our hypopharynx, which cause laryngospasm, which later on cause hypoxia. Whereas wet drowning is caused by the fluids, also by the laryngospasm and the fluids into the lung, causing the washout of the surfactant and losing the surface tension and causing the atelectasis and later on causing the hypoxia.
Why you put oxygen?
This one actually the recommendation by this research.
No, why? There's a reason why you put why is it? No, they say it's oxygen because nowadays you cannot define dry drowning anymore because the patient dry drowning, like what I told Metan time, is the first 1 minute or so. The moment the patient lost the reflexes, the patient wouldn't die at that time, and then wet drowning comes along. That's why it's oxalic, because there's no such thing as wet and dry. It's actually a combination. Well, it can start off with dry, but later on it becomes wet anyhow because of the lung becomes flooded. Okay.
Apart from that, there is some new theory. They actually developed new theory in terms of the causing of the drowning itself lah. Whether by when our brain is having hypoxia, okay, this one the epidemiology never mind. So pathophysiology, you see, we have to consider in terms of the CNS and also pulmonary injury, which we have our other factors contributing to the pathophysiology of drowning lah. But never mind. Complicating factors. This is prior to the drowning. And then this is before pathophysiology before, and then they have a new theory on that lah. Okay. CVS effect because of the apnea causing when our brain is having hypoxia, later on precipitate tachycardia and also hypotension, which later on leads to bradycardia and hypotension, and then this cause the blood shunted to the vital organ and decrease the perfusion to the extremities such as muscles. So basically when patient is having drowning, patient also having weakness of the extremity, the patient cannot swim, causing the swimming failure, causing the wet drowning lah. This is actually accelerated in cold water. The other theory, the act is actually in terms of the autonomic conflict. In terms of the when patient dive into the water, we have diving reflex, and also when patient was introduced with cold water, we have cold shock response. So diving reflex causing the bradycardia via the parasympathetic activation, while the cold shock response causing the sympathetic activation. So this proposing effect is actually prone to high risk of the arrhythmogenic state, which later on can cause arrhythmia. So this is actually underreported as well because of death. So
okay, we better stop. I just want to give one remark only. Yeah, this is very important for you to understand. In a swimming pool or in a place where you will see people swimming, because there is this situation that when you fire yourself not too much, you get to take it. And then you can get heart attack. During a heart attack situation, you can die, and then at the time you'll be floating. Okay. Now this is what happened to that pediatric lecturer who actually swimming at the KLGC swimming pool, and she was swimming, and then suddenly they found her floating, and then they went and saw her there, and then they did CPR and so on. Then everybody talked about drowning, and everybody said, how in the world that this lady who's been swimming and then can die in a swimming pool? Then they did postmortem, and they found that the lung is dry. So when the lung is dry, it means that at that phase, when you have heart attack and you have all the things that you said just now, that time the patient died because of heart attack. I haven't drowned them. So if you get the patient early, you can, and then do resuscitation and so on, it will be a dry lung. But in this girl, it's only a wet lung. You can see all the things that you see. Now there is a different approach to management. Now that is still existing, the concept of dry drowning, but the cause of dry drowning is more of the cardiovascular, sympathetic, and so on. You understand? But you can only identify dry drowning when you get it at that point in time, when it is before it goes and becomes